Rheumatoid arthritis is a chronic, progressive inflammatory disease. It can affect tissues and organs, but usually it attacks the joints, producing inflammatory synovitis. It involves joints bilaterally and symmetrically, and it typically affects several joints at one time. It is an autoimmune disease, and is precipitated by WBCs attacking synovial tissue. The WBCs cause the synovial tissue to become inflamed and thickened, and the inflammation can extend into the cartilage, the bone, the tendons, and the ligaments that surround the joint. Joint deformity may result from these changes, decreasing the range of motion of the joint and the function. It is also a systemic disease that can affect any connective tissue in the body. Common structures that are affected are blood vessels, the pleura around the lungs, and the pericardium. Within the eye, you can see iritis and scleritis of the eyes. The natural course of the disease is exacerbations and remissions. So it flares up and then it goes into a remission, and it flares up and it goes into a remission. We want to make sure that our patients have as much a quality of life as possible. We want to prevent any deformity from developing and inflammation of their joints. We want them to use adaptive devices if needed. And we want to try and maintain function and range of motion. Risk factors for this disease, we see it in women ages 20 to 50 years. There is a genetic factor to it, a genetic predisposition. And it's also related to the Epstein-Barr virus, as well as can be attributed to a stressful event in the life right prior to it coming on. Early signs of rheumatoid arthritis, which is fatigue and joint discomfort, are really vague, and they can be sort of attributed to other things with older adults, just the aging process itself. And having that joint pain and that dysfunction for the older patient, can also be due to the presence of other chronic conditions, so it's going to have a bigger effect on them. Older adults are less able to overcome and cope with that joint pain and deformity than a younger individual can adapt more readily. So what do we see? We see pain at rest and with movement. So they're in pain if they're at rest or moving, which is different from osteo. They wake up with morning stiffness, and that takes a while for it to subside. So that is significant with rheumatoid arthritis, is that morning stiffness. They may have pleuritic pain, which is pain on inspiration, xerostomia or dry mouth, anorexia, weight loss, fatigue, paresthesias, and we want to know if they've had a recent illness or stressor prior to an exacerbation or diagnosis. Clinical findings depend on what part of the body is affected by the disease. Joints, swelling, fingers, hands, knees, wrists, joints are usually affected, feet. The finger joints are associated with proximal interphalangeal and metacarpal phalangeal joints. They may become deformed merely just by doing activities of daily living. They just become deformed. So we see ulnar deviation, swan neck, boutonniere deformities there in the fingers, and the next slide has a image for you to look at, or one of the slides do anyway. They could have subcutaneous nodules and low-grade fever, muscle weakness, atrophy, and like I said, that reddened sclera in the eyes, or also abnormal shaped pupil. Lab tests for rheumatoid arthritis include anti-CCP antibodies. That would be positive. This test detects antibodies to cyclic citrullinated peptide. The result is positive in most people who have rheumatoid arthritis, even years before they get their symptoms, and it is more sensitive to rheumatoid arthritis than the actual rheumatoid factor antibodies. So that brings us to the RF antibody, and its diagnostic level for rheumatoid arthritis is 1 to 40 to 1 to 60. Because normally we have a 1 to 20 or less ratio. High titers correlate with severe disease, so the higher the titer, the more severe their disease is. And then other autoimmune diseases can also increase the rheumatoid factor. Erythrocyte sedimentation rate, or the ESR, it would be elevated, and it's associated with inflammation or infection in the body. So 20 to 40 is mild, 40 to 70 would be moderate, and 70 to 150 is severe inflammation. Now, other autoimmune diseases can also increase that ESR antibody. The C-reactive protein, that they may take that instead of the ESR antibody, and that would be positive. It's used for diagnosing a disease or monitoring a disease activity, and it's a response. They look at how an individual responds to anti-inflammatory therapy. And then the ANA, or the antinucleic antibody titer, is an antibody produced to one's own DNA. A positive ANA titer is associated with rheumatoid arthritis. It's positive in rheumatoid, but not positive with osteo. So that's another indicator where they differentiate between the two of them. And like other autoimmune diseases can have an increased ANA, like lupus has increased ANA. The individual may have elevated WBCs, and they'll be elevated during their exacerbation, and that's because of the inflammatory response. So other diagnostic procedures is arthrocentesis, where they go and aspirate the synovial fluid with a needle. If the patient has rheumatoid arthritis, they're going to see increased WBCs and a rheumatoid factor in the fluid. If they have had this procedure, we're going to be looking for bleeding, making sure there's no synovial fluid leaking from the site, and we treat them typically with Tylenol for the pain. X-rays may also be done, and it's used to determine the degree of the joint destruction and monitor the progression of the disease. The X-rays give a real good visualization, and they don't really need to do other tests like MRIs or CTs, because they see what they need to see with a traditional X-ray. Okay, so what do we do for care for these individuals? Well, we use hot and cold therapy. It's indicated on how the client responds, like their morning stiffness, they might need a hot shower. The pain in the fingers, they can use a hot paraffin wax treatment and soak their hands in the paraffin. If they have edema, maybe a cold therapy would be helpful. We want to assist and encourage their physical activity, maintain as much range of motion as possible, monitor for signs and symptoms of fatigue. We're going to teach them how to maximize their functional activity, minimize their pain, and conserve their energy. Make sure we have a safe environment with assistive devices in place, remove any fall risk items, administer meds, monitor for medications, effectiveness, pardon me, pain and meds. What do we use? NSAIDs. Typically we use NSAIDs. We're going to request that the patient get a concurrent prescription for proton pump inhibitor or an H2 blocker to decrease the GI acid with the NSAIDs. We're going to look for fluid retention, hypertension, renal dysfunction, all those side effects. Pardon me. Corticosteroids such as prednisone, very strong anti-inflammatory agent, can be given for acute exacerbations or for advanced forms of the disease. Try not to give it for long-term care, although we all know that it is sometimes. We're going to look for Cushingoid changes, look at their weight, blood pressure, that kind of thing. The disease-modifying anti-rheumatic drugs, the DMARDs, they work in a variety of ways to actually slow the progression of rheumatoid arthritis and suppress the immune system's reaction to the arthritis that causes the pain and inflammation. This might take a while for it to work. Actually, relief of these symptoms may not occur for several weeks. DMARDs include anti-malarial agents such as Plaquenil, antibiotic, minocycline or minicin, sulfonamide. Pardon me again. Sorry. Biologic response modifiers like Enbrel, that one's being advertised on TV right now. Remicade, Humira, it's also given sub-Q. These are sub-Q agents primarily. Cytotoxic medications like methotrexate or Rumitrex. And if we put patients on cytotoxic medications, we better make sure that they're not pregnant. Individuals with rheumatoid arthritis really do need OT and PT referrals. Occupational therapy can help them with the adaptive devices that can actually facilitate carrying out their ADLs and actually help prevent further deformities. We may need actually to have them have home health assistance as well. Plasmapheresis is also used, and it's only done with a life-threatening exacerbation, and that's where it removes the circulating antibodies from the plasma and it decreases the attack on the individual's tissues. Surgical interventions we might see is a total joint arthroplasty, and that's done if there's no response to medication therapy. Complications include the Sjögren's syndrome, which is a triad of symptoms: dry eyes, dry mouth, and dry vagina. It's caused by an obstruction in the secretory ducts and glands. So we want to treat that with eye drops, artificial saliva, lubricants, and lots of fluids with meals. They could get secondary osteoporosis. So immobilization caused by the rheumatoid arthritis can contribute to the development of osteoporosis. So we want to make sure that they can do weight-bearing exercises as tolerated. And then vasculitis, which is organ ischemia. Pardon me. Inflammation of arteries can disrupt blood flow, causing ischemia, and the smaller arteries in the skin, eyes, and brain are the ones that are most commonly affected by rheumatoid arthritis. So we're going to look for skin lesions, a decrease in vision, and any symptoms of cognitive dysfunction.